And next we'll hear from Deanne. Deanne Bacvar is a registered nurse who has been working at Timmins and District Hospital since 2014. Deanne earned a Bachelor of Arts degree from the Moral University in Newfoundland, a Bachelor of Science in Nursing from Laurentian University, and a Critical Care Nursing Graduate Certificate from Durham College. Deanne began her nursing career in the emergency department, where she continues to work today. Deanne has also trained and worked in critical care. And as a member of the ER team, Deanne has worked with the stroke program, delivering educational seminars to new telestroke sites, and also worked as the stroke nurse for TDH this past year before returning to the ED. Deanne has practical experience in caring for patients throughout the care continuum, including the ER, ICU, stroke unit, and secondary stroke prevention clinic, which enables her to provide insight and expertise in the stroke care continuum and patient pathway. Later, Deanne will be joined by Nicholas Noob. Nick is a registered nurse who worked on the medical unit at Timmins and District Hospital beginning in 2014 after graduating with his Bachelor's of Science in Nursing from Laurentian University. After 3 years of frontline care, Nicholas transitioned to the role of stroke clinician. In this capacity, Nicholas worked directly with stroke patients and their families on the inpatient unit and in the stroke prevention clinic. In 2019, Nicholas started in the role of district stroke coordinator. And in this role, Nick has been involved in many regional projects geared towards improving access to and optimization of stroke care. Thanks, Nick and Deanne.
Thank you, Susan, for that kind introduction. And thank you to the Northeastern Ontario Stroke team for allowing me to have this experience with you today. Nick and I, together, we're going to be discussing a stroke care path and the importance of using a systematic and standardized care plan. So I'm going to start off the presentation with more of what my knowledge base is with the emergency ICU aspect, and then Nick will take over from there. So our learning objectives for this session is to educate you, the participants, on the importance of following a stroke care path, to ensure that all providers involved in stroke care understand the link between stroke care pathways and optimizing stroke patient outcomes, to highlight the importance of implementing and utilizing inpatient stroke protocol processes, and also to review vital signs, neurological assessments, and stroke order sets that are used. If you could slide down, Nick, for me, please. So first, we're going to look at what actually is a stroke care pathway. So a pathway, they are designed based on evidence-based practice as a means to improve the efficiency and quality of patient healthcare. They provide standardized care that encompasses multiple disciplines to provide timely and optimal care. So we know that research shows that better clinical outcomes and reduced lengths of stay is what transpires after you follow a care path. So because it provides you with that detailed focus on care, specification of documentation, and inclusion of data collection to allow assessments for status of progress towards your goal, or to identify if a patient's conditions change for the worse and that we have to do different interventions. Stroke care pathways can assist the healthcare team to transition from one phase to the next. So as I mentioned, my role from an emergency nurse to an ICU nurse, we have different stroke care pathways that we use throughout the continuum of care. If you could scroll down, Nick, thank you. So when does the care plan start and end? So essentially it's immediately the patient identifies, I think I might be having a stroke. So we're looking at EMS, the emergency department, acute care, the stroke unit staff, the rehabilitation staff, and outpatient services. So it goes from right to the beginning to right to the end, even after the patient is discharged home. If you could scroll down, Nick, thank you. So everything varies by department, as I mentioned. So if you have the hyperacute stage, this is where it's going to involve EMS passing over to the emergency department. And then we're going to be looking at what happens when the patient is transferred, whether it's to another facility for EVT or to our ICU or straight to the stroke unit. So every department has their own order sets that are there in order to make sure that care providing at that point in the patient's journey is what's best practice as outlined, okay? So if we look for the code stroke emergency pathway, so we look at, in terms of emergency, it's a coordinated effort. There's a lot of people involved. It's very time sensitive. And so all the players that are involved need to know the role. So we need to know when a patch comes in that we're expecting a stroke bypass, or if our triage nurse says, hey, Deanne, you know, I think I have a stroke in the waiting room. Everybody knows exactly what they're supposed to do and how to activate the process. So we always remember that time is brain. So that's always in the background in my mind as an emergency nurse, that, okay, this is happening and we need to get the protocol started right away. So if you could scroll down, Nick, that would be great. So as I mentioned, there's 3 ways that we're going to encounter a stroke patient. We're either going to be receiving a call from EMS saying, I have a stroke bypass coming in, or a local stroke, or triage nurse, whether that's myself or another RN, is going to say, I have this patient that is displaying fast symptoms and I think they're having a stroke, or we hear the overhead inpatient stroke protocol. So those are the 3 pathways in our hospital, at least, that we're going to encounter a stroke patient. So when we do, as the RN, is whether or not I'm receiving that patch from the EMS or from a triage nurse, we're going to initiate the process right away. So we're going to make sure that we notify CT technicians that we have a stroke. They're going to clear our table for us. We're going to know that the lab technicians and admitting staff and our emergency colleagues, including my physicians, are all ready, and we're ready to start the time clock from there. So not all sites have a code stroke. I know our department doesn't. We just activate in-house. We don't call it overhead. The inpatient stroke protocol we do, but your facility might be different. I'm not sure from region to region. So in our particular facility, the trauma RN or the charge nurse will start to activate the process. Okay, so as long as you know your role and your specific institution's guideline, that's the key part here, is that we need to know there's a care pathway in place and that all the players know what their role is in this. So if I'm arriving from the waiting room thinking I'm having a stroke, so I'm going to be sitting in front of, in our department, you see the admitting staff first. Often they'll alert us, I have a possible stroke here. So patients are asked directly to go, the signage is in the waiting room. If you think you're having a stroke, go let someone know. As a triage nurse, I'm going to be doing a quick fast test, and I'm going to be making sure that I look at the last seen normal and obtaining a glucometer. So it's essential that I do a focused assessment based on best practice in order to see, is this patient within the window? Is there a possibility of EVT for that extended window? And I need to get them C-test 1. I need to have them transferred onto an ED stretcher. And the first thing I do is grab my emergency physician and say, identify this as the C-test 1 possible stroke. I need you to take a quick look at my patient. So they're trained to do and act fast. They're going to make sure, of course, that they agree with my assessment, the timelines are solidified, and then they activate the stroke protocol. So we notify CT stat that we're on our way over. Another nurse in our department will grab the VCC Tamberg, get trauma set up, and then we notify. In our institution, we use the stroke team. Other institutions, I understand, might be emergency physician that's going to be starting and finishing this process until the patient's transferred, or you have a neurologist on site. So the key component of this is to activate the care pathway and to get the patient to CT stat. If you're arriving by EMS, similar process. As soon as we get a patch that comes in, hopefully we're pre-registering the patients and we're already putting in that order for CT. We're calling them saying we have someone 5 minutes out. Again, making sure all the players are aware that this is what's coming in. So an ABC is done on arrival from EMS by the physician, because ideally they're waiting for them as soon as they roll in. They're not offloaded. They do a quick ABC and then they do their quick act fast. And then are we activating? Or are we not? So the decision is made. Yes, we're activating. We go straight to CT. This trauma nurse accompanies, again, will accompany the patient. They stay with the patient through the entire process, whether it's triage or EMS, and then you're offloading in CT. So oftentimes my stroke physician in our facility at this point is either arrived and we know this We let our admitting staff know or another nurse to activate telestroke right away because we are a telestroke site. And we make sure that the images are pushed through ENITs because we want no delays. Because as we know, CT scans, optimal is 10 minutes from the time we enter the emergency. We're supposed to really be focusing on making sure that nothing deters us from that CT scan, nothing slows us down. So, you know, in terms of getting the story from EMS, the physicians get the handover as soon as they come in, and it's concise. It's last seen normal, glucometer, deficits. They do their quick assessment. So there should be no delays in any of this process. So if we look at it in terms of our trauma bay, we have a stroke box, which has all the elements of TPA there. So nobody's scrambling looking for anything. And we also have documentation and paperwork that we have set aside. So we have various order sets. So a patient that comes in and is a stroke, if we're looking at an acute ischemic stroke that I'm looking at possible TPA, I have a pathway for that. If it's a hemorrhagic stroke, I have a pathway for that. If it's a resolving stroke and it's a high risk TIA, I have a pathway for that. So regardless of the way that we're going to go, there is set documentation and paperwork and set pathways. So it guides the nurses and the physicians in order to know what to order and what to do. So this is just a kind of an example of the order set. This is the one that we use for TPA. So this is pre-TPA admission, so last seen normal, code status, and it has criticals number in there, so nobody's scrambling to find the phone number. So this will guide nurses and physicians into step-by-step what are we looking at, you know, what is the NIHSS score? So, and we'll talk about that a little later. What are our blood pressure? What is our baseline vitals looking at? It tells you how to mix the medication, how to administer it. And then it also goes through after monitoring what interventions should we be doing, what should we not be doing? Because as we all know, this is a quite stress producing time. We're trying to do everything as quickly as possible and have the best patient outcome. So we want to make sure that the nurses involved and the physicians take the time to slow themselves down to read through these order sets, because doing that will help make sure the patient gets the best care possible, because we're not going to miss anything. Again, best practice guidelines, right? So when we're looking at it, if I've TPA'd a patient, I know I need to keep my patient NPO. I need to do a swallowing assessment. So whatever your facility uses for that, we use a TOR best, and you have to be certified. So it shows you if a patient's nausea, vomiting, if how you manage the glucose, it gives you everything. So if we move on from there, Nick. So assessments and interventions, I pretty much outlined these all. So lab work, a lipid panel will be involved in that, like ours has an HbA1c, ECG, stat glucometer, and medical profiles. So neuroexam and IHSS, if you're not certified to administer that, then we would be looking at the CNS. Make sure you do 2 large bore IVs. And then what if the CT shows a hemorrhage? We all know we're not going to be TPAing. And as I mentioned before, we're going to that other care path. So if my physician tells me, yes, you know, this looks like an acute ischemic stroke, and we're going to be looking at activating telestroke, we place the call. It's done as soon as possible. Telestroke then will help guide us, assigned a neurologist that will help us review. They will do their assessments and then guide us in the care. So you're either going to go one or two ways. You're either going to go through a telestroke, as I mentioned, or you're going to go through a non-telestroke pathway, and then you're not using telestroke as a third party. So whatever your facility utilizes. So the non-telestroke pathway, this was designed in order to help give us a quick guideline on what to do. So when do you really get a telestroke consultant involved? We have to remember these people are very busy and getting calls. So we need to make sure that we're not calling them for something that we shouldn't be calling them for. So we're doing a FAST. If it's positive, the triage nurse again, CTAS 1, and then we get the emergency physician involved. So the key parts of this is looking at when is it last seen normal. So for a patient to come into triage and say, I think I might have had a stroke, I woke up this morning with, that will trigger me as a nurse to take a look at the time. Is this within my window, or is this extended window possible EVT? So when you're doing that EVT part here at this section after the ED physician has kind of looked and said, okay, you know, is this patient bedbound? Is this patient demented? And I'm going back, I apologize, I missed that part. Can the patient recognize family members? They can't be left alone, or they're at the end of life. So we're not going to activate telestroke for that. So if the patient passes that particular step, then we go on to the last scene normal. I apologize for that. So do the patient have persistent symptoms? Do they have a positive act fast screen? That's very important for that 6 to 24 hour pathway, because we know for there that we're looking at possible EVT, and that CT, CTA is essential. So as we're following this pathway, it looks like as long as we're following it through, we're doing the best thing for our patient, and it gives us recommendations. So we know when to activate telestroke, so that and we're not calling them for something that we should have known that they don't qualify for. So if we continue on, and on that note, in the nursing documentation that we have in trauma, included in the physician's documentation, which we give them as soon as they arrive, it involves the inclusion exclusion criteria. It involves the telestroke, physicians, the billing information and such, so it'll help them. So what are our risks of not following this standardized care path? Well, the patient doesn't get the proper interventions. We may miss the timeline or opportunity for hyperacute care, and they didn't get the proper testing. So all in all, it will increase the patient's level of stay, length of stay, my apologies, and also decrease positive patient outcomes. And we know that that's what research indicates. So door to CT, we know within 10 minutes of arrival. These are a few benchmarks that I've mentioned throughout, but it's important to reiterate. Critical should be contacted for telestroke services as soon as possible after the CT, and you have to fill out that telestroke referral worksheet. And then whether or not we're looking at TPA or EVT. So that indicates, are we going with this? Are we not with telestroke? Median door to needle is 30 minutes, and with 90% of patients within the 60-minute. We have to remember that not all sites have on-site CT technicians 24 hours a day, and we have to call in people. So we recognize that. So we're looking for that 60, and door in, door out time for patients with EVT, 45 minutes or less. Again, we're in the north, right? So we have a lot of weather issues, transportation issues and such. So oftentimes, you know, our preferred site is EVT for EVT is HSN, of course, now doing 24/7 service, but sometimes our patients are rerouted just simply for weather. So we have to keep that in mind. So very quickly, I'm going to take a look at the ICU care path. So I've already mentioned this, that if a patient has thrombolytics and are not going to be going for EVT, they will transition to the ICU for 24-hour care. If it's a hemorrhage that presents to the emergency department, the hemorrhagic stroke, they have their own care plan. If it's deemed they're critically unstable and they need to go to the ICU for monitoring, they'll be transferred there as well. So it depends. Both have their own care path. So if we click on the hemorrhagic, so we all know that that's about 20% of strokes. We know the causes and etiologies of it, but we do know that we have to make sure that their blood pressure is strictly monitored. There's very, very tight parameters, which is why it's important for ICU to take over care, because that's the only site that we can make sure that one-to-one nursing and the consistent monitoring of blood pressure, neurological status, and other vital signs. So if we look at the ischemic stroke side, if it's a TPA, these are what we're going to see most likely 80% of the time. And if a patient has TPA in, then we have strict guidelines based on best practice of how often we're checking vitals, when we're doing blood work, when we're doing repeat CTs, etc. So key components of ICU is using the multidisciplinary team. So everybody's involved, the internist and our end, the stroke physicians still follow up. We have SLP, PT, pharmacy, nursing staff, everybody's involved. So we look for complications. We do monitoring always to see, like, has somebody converted into a hemorrhagic Like, are they hemorrhaging right now? Is there angioedema? Is there anything that's coming up, a change that we have to start to look at? What are we going to do here? Do we need repeat imaging or not? So there's a few basic things, like we put the patients on 24-hour bed rest. We make sure there's no invasive therapies because we don't want this patient to bleed, especially after TPA, and then intense neurological and vital signs. Okay, so going down to angioedema, I believe Dr. Kavaz talked about this, or will talk about this in his presentation. So angioedema is something that can occur post TPA, and we have a pathway in place that if this happens, we have specific medications and interventions to keep the patient's airway patent and to deal with this. So that's what it looks like. Hopefully we never see it. But if we do, of course, we have that pathway in place to help us. So vital signs, we know that NIHSS is best, but we can also look at a CNS. We're looking at post TPA in the trauma bay is usually Q15 times by an hour, then Q30, then Q2. Always looking to see for hemorrhages, it's case dependent. And so it's important to look at those local order sets. They're there to guide you. I mentioned blood pressure management for hemorrhagic is tighter, like restrictions. We want to keep those parameters really, really tight. But for post TPA, we're looking at 185/110, and our care plans point out exactly what medications and interventions we're doing to control that and when to call the physicians in. If you could scroll down, Nick, thank you. So Canadian best practice guidelines, I'm not going to read through this one-to-one, but we do know that all sets of vital signs are important, whether it's temperature, blood sugar, fluids, and neurological changes. So that's why that 1-to-1 24-hour critical care is essential for patients, because this is monitored consistently. So they have the expertise and tools in order to be able to do this. Scroll down, please. So NIHSS, we know, is that 15-item impairment tool. It's way more encompassing than a CNS and looking at neurological deficits. It is a preferred tool to look at the stroke severity and the degree of recovery for patients. We all know it's different levels after you've done your NIHSS, and then decisions are often made on whether or not we're going to go ahead with treatments like TPA, EVT, based on the severity of the stroke. So you must be certified to use this tool, and it's important that you follow the tool correctly so that there's a concise recording of the patient's stability at that point. Like, what are they presenting with at the time? So the NIHSS is really good, so that takes a lot of the subjectivity out of it, so that you know exactly that from one assessor to the next that you're getting similar results. So we always want to remember, and this is often forgot, that patients need a swallowing screen. We try to do this in the emergency department. If the patient fails, we try to contact SLP right away. But on every order set, on every pathway, it always mentions patients should be NPO until it's assessed. So that's something that's essential, and Nick will talk about that further. So at this point, I've run through what happens at triage or EMS. I've discussed what happens in the emergency department, the acute, the hyperacute pathway, and what happens within our ICU. So it's very important just to remember that every site probably has their own care paths in place. I know we do at TDH, and as a nurse, I always know this is my diagnosis. I have to get this care path, and it's going to help me guide my care. So just familiarize yourself with that. And at this point, I will hand it over to my colleague, Nick, and he will go through the rest of the pathway with you. Thank you, and I hope you enjoy your conference.
Good morning, everyone, and thank you, Deanne, for the warm welcome. So I'm going to talk a little bit about stroke unit and rehabilitation care. So I'm going to start off the segment with highlighting a couple quotes that I've received, that I've gathered from the Canadian Stroke Best Practice website. That goes a long way in showing how it is important to have stroke patients looked after in an acute stroke unit. So patients admitted to hospital with an acute stroke or transient ischemic attack should be treated on an inpatient stroke unit as soon as possible, ideally within 24 hours of hospital arrival. The reason for this is multifactorial, and I'm going to list a couple more quotes that I thought were very very profound in highlighting why this is important. So stroke unit care reduces the likelihood of death and disability by as much as 30% for men and women of any age with mild, moderate, or severe stroke. It is characterized by a coordinated interdisciplinary team approach for preventing stroke complications, preventing stroke recurrence, accelerating mobilization, and providing early rehabilitation therapy. So evidence suggests that stroke patients treated on acute stroke units have fewer complications, earlier mobilization, and pneumonia is recognized earlier. Access to early rehabilitation is a key aspect of stroke unit care. For patients with stroke, rehabilitation should be started as soon as possible. And so on this presentation, which I'm not sure could be shared, there is a link to the Canadian Stroke Best Practice website. And it goes into more detail as to why it is important to have a stroke unit. With this said, I recognize that many sites in Northeastern Ontario don't have a stroke unit, and so there are protocols in place and protocols being developed to try and consolidate care as much as possible. And ideally, in an ideal state, and hopefully in the near future state, we'll have a process established whereby stroke patients who are not cared for on a stroke unit will have access to stroke unit care in a prompt and timely fashion. So what constitutes a stroke unit? Well, there are three main components of a stroke unit. One includes volume. Volume is primarily focused, the reason volume is important is because nursing staff and allied health who look after stroke patients should have the expertise, and expertise really only comes with increased volume. And so it is important to recognize that until our multidisciplinary team has that expertise, that's central to a stroke unit. So volume is imperative factor to this. Patients should be located on a geographically defined space. So if patients are spread throughout the hospital, it would be very difficult for allied health and nursing staff and physicians to develop this expertise. So it essentially goes hand in hand with volume. There are multiple factors why this is important, but namely this is one of the most important. And stroke units are supported by the multidisciplinary team, and we'll go into a little detail about this coming up. So what are some guiding principles of acute stroke unit care and rehabilitation care? Well, first of all, stroke patients should be admitted to the unit within 24 hours. This is a general guideline, and there are more specific scenarios that we're going to highlight next. So when patient is not requiring ICU care, so they don't have a large hemorrhage that's needing intensive one-to-one monitoring, patients should be admitted, or they haven't received TPA or any other intervention that requires ICU care. They should be admitted from emergency to the stroke unit within 6 hours. TPA is obviously one of the exceptions to this rule, among others. If patients, for example, receive TPA, they should be staying in ICU for at least 24 hours, as long as there's no complicating factors that makes it necessary for them to stay in ICU longer. Stroke patients should have access to to all interdisciplinary professionals. So I've listed a few here that are critical in the care path for most stroke patients, although I have omitted some, and I recognize there are many other players who are involved with stroke care. So the major players are occupational therapy, speech language pathologist, physiotherapy, pharmacies, dietitians, social worker, nurses, doctors with expertise in stroke care. They should be assessed, stroke patients should be assessed by the stroke team at least within 48 hours, but ideally sooner. Care plans should be established and disseminated as soon as possible upon admission, again, within 48 hours. So stroke units are characterized by a standardized set of assessments and interventions that registered nurses and all allied health should be familiar with. So essentially it's to identify, so stroke unit assessments and interventions are geared to identify stroke etiology. So when patients are admitted to the acute stroke unit, one of the first steps is to figure out, okay, so what caused the stroke and how can we treat it optimally? Next is to reduce, there's a care path is meant to reduce stroke complications, which I know Dr. Kafas talked about. But we'll go into a little bit more detail as to what specifically we should be assessing and intervening on. And then, of course, order sets, which Deanne mentioned, are very critical in guiding the pathway. Order sets essentially create the pathway that should be followed throughout an acute and during acute care and rehabilitation. We have order sets for multiple different admissions. So we have order set for TPA care. We have order set for hemorrhagic strokes. We have an order set for general acute stroke admissions and general TIA admissions. And then there is also a discharge order set. And so depending on the scenario, we'll follow each of these order sets. I won't go into more detail than that. I recognize other sites might have different set of orders, different order sets. However, it's important to recognize their importance, and if your site has them, which I know many sites do, they should be followed and routinely used. So on a general note again, and I'm going to go into more detail into each of these points, but really what is standardized? So first of all, appropriate and timely referrals. When patients are not admitted to a stroke unit, often what happens is appropriate team members are not referred to in a timely fashion. So for instance, if a patient does not get admitted to an acute stroke unit and they're instead admitted to a general acute floor, which does happen from time to time, and depending on, of course, volumes and patient capacity. Often in these cases, patients are not getting the appropriate referrals to the appropriate team members, which could be really detrimental to their recovery. So for example, they may not be referred to speech language pathologist, occupational therapy, dietitian, and so on. So it becomes very clear that patients who are admitted not on an acute stroke unit lose out on the ability to have rapid access to these team players. NPO, patients are NPO until dysphagia screening is done. This is of course part of the order set, and I'm not going to go into more detail at this moment, as I will follow up with this in the next slide. Vital signs and neurological exams are again guided by the order set. We'll talk about this in another slide. Order sets also guide standardized investigations and standardized monitoring procedures. So moving on to this slide, where we're going to discuss swallowing screen. So as Deanne mentioned, and I'll just reiterate, swallowing screens must be completed on every stroke who passes through the hospital. The reason for this is multifactorial. But the most important reason is that patients who have strokes very frequently have some loss of capacity of swallowing. And so we need to assess for this. There are two standardized tools that I recognize are being used in many of the facilities in the Northeast, these being the TORBEST and the STAND tool. Timmins and District uses the TORBEST. And so we're a little bit more familiar with this, but in both cases, they're very validated and standardized tools, and they do a great job in ruling out whether a patient has dysphagia. They both must be administered by certified professionals. Most typically, it's nursing staff who completes them. If a patient fails a TORBEST or a STAND, then they're going to be NPO until a speech language pathologist can assess them. Some sites use a dietitian if they do not have a speech language pathologist. This is a very important tool to be used because if patients go on and start feeding when they should be NPO and they would have otherwise failed the TORBEST or the STAND, then they could go on and develop aspiration pneumonia, which could make recovery very complicated and very much slow down the recovery process of stroke patients. If patients fail these tests, then the process and the pathway should be that they were referred to speech language pathologist, where a more thorough analysis is completed. If it's on the weekend and there's no speech language pathologist and or dietitian to complete a more thorough assessment, then the patient should probably have an NG tube inserted, and this should be advocated for in order to continue with feeding and nutrition, and to maintain nutrition and hydration status. Our site, and I know many other sites in the Northeast, has a standing order for feeds. So this is something that everyone should be aware of and should be followed should this scenario arise. So assessing stroke severity, this piece is very much tied into rehabilitation and patients and is completed by typically allied health. There are multiple tools to assess stroke severity, but the two most common ones are the alpha-FIM and the modified ranking scale. The alpha-FIM, I'm going to talk a little bit more in detail. So it is a tool that assesses stroke severity, stroke function, and level of disability that the patients may be experiencing. It is used typically on day 3 of stroke patient admission, and it is done typically by allied health, most typically speech language pathologists, occupational therapy, or physiotherapy. Upon completion, a score is going to be obtained, and a patient's going to either score between, I believe it goes up to 130. So for patients who score a 40 or less, this is typically considered a very severe stroke where the patient's probably not quite ready for intensive inpatient rehab therapy. If this is the case, they will be reassessed using this tool on a weekly basis and for approximately 1 month. If they continue to be less than 40, then they may or may not receive rehab. But typically speaking, I know most sites will still admit these patients to a rehab unit to give them the opportunity to increase their function. On the upper end of the scale, if patients are greater than 100, then they're more compatible with discharge home and to receive outpatient rehab. With this said, the Alpha PIM is a generalized tool and is not really a hard stop to yes or no to rehab. There's a lot of factors involved with rehab, access to rehab, and certainly this is only one piece of the puzzle. However, it is a fairly big piece and it is a standardized tool that does guide decision-making. Vital signs and routine monitoring. So when patients come to the acute stroke floor, they should be assessed using a standardized neurological assessment, which Deanne had talked about, the NIH and the CNS, as well as vital signs should be monitored every 4 hours for the first 2 days, and then every 8 hours following. This at least is the care pathway that we follow at Timmins District. However, I believe this is fairly standardized across the province. Blood pressure Deanne talked about in the context of hemorrhagic stroke in ICU, as well as post-TPA strokes. I'm not going to go into too much more detail. However, I will state that for patients who are admitted with an acute stroke, typically we're following parameters that are a little bit less specific than TPA. So for example, to patients who have blood pressure greater than 220 systolic or 110 diastolic should be treated as per Canadian Stroke Best Practice Guidelines. Typically, treatment will be to reduce these blood pressures by 15 to 25% over the course of 24 hours. We don't want to reduce the blood pressure too aggressively and too quickly because this could lead to other complications. So in the case of hemorrhagic strokes, it's slightly different. Blood pressure parameters will be specific on a case-by-case basis. And there are many factors that are involved with it, including the size of the hemorrhagic stroke, the patient's age, the onset of symptoms, etc. And so it's important as an RN on the floor to be very aware of these parameters and to be aware when patients are above or below these specific set parameters, and to notify the physician appropriately at appropriate timing. So heart rate is another factor that will be discussed a little bit later, but ultimately what we're looking for is irregularities. Because like I said earlier, when patients are admitted to the acute stroke unit, one of the things we're looking at is the cause of the stroke. We need to identify the cause in order to treat it properly. Very frequently, approximately, I believe, 30% of ischemic strokes will be caused from irregular heart rhythm or a cardiac source. And very often this is atrial fibrillation or a flutter. So the RN on the floor should be looking for irregularities when assessing heart rate. Oxygen is done PRN. This is really not too different to standard care. Only when patient saturations go below a specific threshold, which typically is 95% or 92%. Oxygen, our temperature and glucometer should be routinely assessed. Typically, glucometer is done on every day for 3 days, and then it's discontinued. This can vary from patient to patient, of course. And temperature should be done as per guidelines for other vitals, which is every 4 hours for the first 2 days. If both of these are outside of normal range, it can slow down the recovery process and make recovery a little bit less optimal in the early stages of recovery. So they should be corrected when they're outside of normal ranges. The neurological assessments that we use on the floor and most sites use in the Northeast are the NIH and the CNS. I'm not going to go into too much more detail about this, other than stating that they're very standardized and important tools to identify if there's changes in neurological status. Typically, if we see an NIH change of 2 or greater, it can indicate that there's some process going on that must be rectified. So an NIH of 2 or greater can indicate, for example, a hemorrhagic transformation, expansion of stroke, etc. So we should be having the physician assess these patients as soon as possible. Likewise, the CNS would do the same, where if we see a variation, an increase of score, it could indicate neurological deterioration and thus the need to involve the stroke physician or the most responsible physician. Other nursing interventions and assessments include the following. So I'm going to run through them very quickly. First, one of the things that we often see when patients are admitted to the stroke unit is very frequently, and probably too frequently, patients are admitted with Foley catheters. Foley catheters, of course, are associated with increased risk for infection. So for this reason, it's not indicated. And also Foley catheters do prohibit the ability of patients to participate in rehabilitation. So for two very important reasons, Foley catheters should be avoided as much as possible. Routine monitoring should be done with bladder ultrasounds to see if there is retention, should the catheter be, and should be really the only indication of patients continuing with urinary retention following stroke. Of course, urinary incontinence should not be treated with a catheter, which is never a standard of care. Ensure patients must be seen by the interdisciplinary team, and the reason for this is quite evident. Most patients do require to be assessed and treated by the multidisciplinary team, and so referrals should be made swiftly if they're not already done from the emergency setting. Early mobilization is very important with patients who've had a stroke. The first 24 hours being the exception where a patient should not overexert, typically speaking. This studies do indicate that this could be not as conducive to recovery. However, after this 24-hour period, patients should be mobilized in an early and fairly aggressive fashion, depending on the patient and their level of ability to participate in therapy. Collaboration should occur on a weekly or, well, in the acute setting on a daily basis, and in the rehab setting on the very least at a weekly basis during rounds. However, patients should be rounded on a daily fashion between nurses and interdisciplinary team, including the physicians, to discuss any changes to the care pathway or care plan, changes in therapy regimen, etc. Patients admitted on the acute stroke floor and in the rehab setting should be assessed for VTE prophylaxis. Venous thromboembolism are very common following stroke. And this is particularly true for patients who have severe and profound weakness that makes them more bed rest than they typically would be. And so it's very important to treat this promptly, and if it's not treated already, to bring this up to the physician. I know Dr. Kafas has talked about the VTE prophylaxis guidelines, and they should be followed when and as necessary. Patients following a stroke often may unfortunately develop post-stroke depression and fatigue. Typically, the onset of this is up to 3 months after onset of stroke symptoms. However, it can be immediately after the onset of stroke, and so they should be assessed on the acute and rehab floor. If they are identified, they should be brought up to the physician to make appropriate treatment plans. There are varying tools that can be used for post-stroke depression and fatigue. Some include the PQ9, which is a standardized tool that's used in many facilities, the Hospital Anxiety and Depression Scale, the SADQ, which is the Stroke Aphasic Depression Questionnaire, etc. So many tools are used provincially and regionally to assess for post-stroke depression and fatigue. We've talked about dysphagia earlier and how it should be assessed. Like I said, many patients come into the hospital after stroke with some form, whether it be mild or severe, of dysphagia. As a result, they may become dehydrated or malnourished in time. And so this must be assessed and picked up on immediately. If this is identified, referral should be made to dietitian promptly. This, in my experience, does happen more frequently than not, where patients become dehydrated or malnourished, and it's not necessarily picked up very quickly, as it is something that progresses somewhat insidiously. But certainly can lead to more complications and slow down the recovery of the patient. Post-stroke seizures are fairly common, so they should be assessed for routinely. Typically, interventions are done if they're recurring after the onset of stroke. Post-stroke seizures do occur from time to time during the onset of stroke, and so typically treatment only occurs if it's happening more frequently. And then, of course, the last point is patient and family education should be done throughout the admission and throughout each transition phase. So when they transition from ICU to acute, acute to rehab, and rehab to home. This makes sure the family and patient are familiar with what the care plan is, what's happening, what kind of changes are occurring in their care pathway, and why it's important for these changes to occur. This really leads to smoother transitions from unit to unit, and then when they are ready to go home, it makes things much simpler to transition. Order sets have been mentioned a couple times throughout the presentation, but I'm going to reiterate the fact that they really do guide stroke patient care and really do make sure nothing is missed from an intervention perspective, from a diagnostic perspective, or from a medical medication management perspective. Stroke etiology, again, when patients are admitted to the stroke floor, one of the most important things that we have to do in the acute setting is to identify the cause of the stroke if it's not already done from the ICU or emerge perspective. So often patients have a repeat CT or CT angio. This is to rule out any stenosis, which should already be identified in the emergency setting. But it also can rule out any other pathologies, as some patients are admitted to the stroke unit when in fact something else is happening. And if a patient is admitted to the stroke unit, a follow-up CT scan can identify and characterize the ischemic stroke, or if there's any extension of stroke, or if there's extension of hemorrhage. Likewise, the MRI can be done to do the similar thing as the CT. It's a little bit more detailed imaging and provides a little bit more details about if a patient has a lacunar stroke. So that would be a stroke that's in the more distal part of the arteries. It's generally done and most effective when done within 24 to 48 hours, as that's when it's most easy to characterize from a diagnostic perspective, these smaller strokes. It is more sensitive than the CT scan. Loop and telemetry. So loop monitoring is typically done in an outpatient setting. Often we do 28 days of monitoring to rule out atrial fibrillation that happens on a paroxysmal basis, where it happens very infrequently but could cause stroke. But when the patient's admitted to the floor, we should have telemetry set up for at least a couple of days to see if there's any underlying atrial fibrillation or atrial flutter, which could, of course, be the cause of the stroke. Echocardiogram is not done on every patient, however, can be done on many patients, in particular those who have had no known cause of stroke. Vascular imaging is normal, and there's no contraindications for anticoagulation. These are really the ideal candidates for echocardiogram. And again, the purpose is to rule out thrombus that's in the heart or any atrial septal defects, among others, but those are the big ones. Lab work is very important. The big ones are of course, the routine lab work paints somewhat of a picture, but on an outpatient setting and if patients are ready to go home, secondary prevention therapy should be initiated and are typically guided by HbA1c to see if there's any underlying prediabetes or diabetes, as well as lipid profile to see if there's any hyperlipidemia that could be contributing to plaque buildup, which could lead to stroke. If a stroke cause hasn't been found already, patients should have coagulation studies to see if there's coagulopathies occurring. And then, of course, the last study could be a loop carotid Doppler, to characterize blood flow in the carotid arteries. This is done on some admissions, depending on the CT angio outcome. Medication management, again, we'll be following orders from the physician, which is often through the order set, but not always the case. Patients should be started on dual antiplatelet therapy or antiplatelet therapy, depending on many factors, including NIH. VT prophylaxis will be initiated. Anticoagulation is done on select patients who have, for example, atrial fibrillation and there's no otherwise contraindications, thrombus in the heart, etc. Blood pressure and lipid profile, lipid stabilization medication should also be initiated on most patients, in particular ischemic stroke patients, to reduce the risk of secondary stroke occurrence. Hemorrhagic stroke is slightly different, of course. Most of the medications I mentioned for ischemic stroke aren't going to be initiated. It really depends on a case-by-case basis, the nature of the hemorrhagic stroke. If it's a hypertensive type stroke, which most hemorrhagic strokes are, blood pressure management would be, of course, one of the most important pieces of the puzzle. Otherwise, VT prophylaxis is going to be a little bit different. We can't really start them typically on medical prophylaxis, so it would have to be mechanically based. So we went through quite a few aspects of stroke care. So if patients are not admitted to a stroke unit or are not receiving stroke care based on a standardized pathway, which which unfortunately is the case in some scenarios. The complications that occur, the risks are high as a result of not following, as a result of missing things that otherwise shouldn't be missed. So the result of this could be the emergence of complications, poor and slow recovery, increased likelihood of death and disability, as was highlighted in the first quote that I read to you as I started the presentation. So I'm going to go through a little bit of the inpatient stroke protocol. This is a very important piece to stroke care, and is applicable to essentially all units throughout the hospital. The inpatient stroke protocol is really a standardized protocol to provide guidance to rapidly assess and treat patients who develop stroke signs and symptoms while admitted as an inpatient. There really should be a standardized process. Nurses coming from Emerge really are familiar with the process of treating stroke patients. However, those who are working on the inpatients don't really get to experience the hyperacute portion of stroke care. And so for that reason, having a standardized pathways might make things a little bit easier and more systematic and more fluent as when unfortunately these scenarios occur. So I have an example of what the Timmins and District inpatient stroke protocol looks like. It is a 15-step process, but really can be broken down into a couple simpler steps. And it's going to vary from site to site. So I won't go into each step in particular here, but I will state what the guiding principles are. So ultimately, what nurses should perform if they have a patient experiencing an inpatient stroke is they should provide a completed comprehensive assessment, which would include the last time seen normal, their neurological status, their vital signs, and their glucometer, which could be a stroke mimic. After this is completed, they should be contacting an appropriate physician. In the case of Timmins and District Hospital, this would be the on-call stroke team, but this may not be the case for every site, and that would vary from site to site. So be familiar with who your most responsible physician is for managing acute strokes as an inpatient. In Timmins and District Hospital, we do an overhead code stroke announcement. This again may not be the case for every site, but it's important for mobilizing every player of the team. So the key players really are lab technicians, DI, so CT scan, as this will be done on a stat basis, and in our case, ICU, because this is where the telestroke consultation will occur. So once a code stroke is established by the most appropriate physician, likely the next steps will be to get the patient to the CT angio suite. And this should really be the first step. So the primary nurse of this patient should be responsible for bringing the patient onto the stretcher, but at the same time delegating other nurses to make sure that they're ordering the proper tests on order entry on Meditech system. If you don't use Meditech, then whatever system that you may be using would be this task should be delegated. The primary nurse should then bring this patient down to CT scan where they have a CT angio to rule out bleed or to rule out any significant stenosis that could be amenable to EVT. Once this is established, a location for consultation should be clearly established as per your site. Again, for us, it's the ICU. So what are the risks of not following this protocol? Really delayed treatment or no treatment at all. I've seen cases where patients who have had a stroke as an inpatient have not received treatment and probably would have been better off coming through the emergency setting. So really these are major misses and should not occur at any point in any facility. So having this standardized process and approach to providing care for these patients is critical. So discharge planning. This is important throughout the patient's stay. When patients have stroke, their journey is very long and it can be very long and in many cases is lifelong. So as they're going through the hospital, they should be very clear. There should be a lot of education and patient guidance provided by every player of the interdisciplinary team. And this is to make sure patients and family are very aware of what to expect when they transition from unit to unit and when they transition, most importantly, from rehab or acute to home. So having this, providing education to family and patients should be done really on a daily basis from the RNs. However, as discharge is becoming more likely, meetings should ensue to have a full-on conversation so that the patient and family really have a broad and fully encompassing understanding of what to expect when to go home. Part of the discharge planning is to establish a DC date when it is feasible. So when we know the patient's likely going to be here for 2 weeks or 2 months, this should be told to the patient and to the family so that they know what to expect and have a timeline mentally established in their brain as to when to expect certain benchmarks to be made. And then so when it's time for them to go home, they feel prepared and adequately understanding of the situation. On discharge, follow-up plans should be established. So there are multiple different scenarios that could be the case here. Often there's going to be home care established, so it should be established and fully communicated to the patient and family. There should be really no question marks here. The patient may have to have follow-up with their family physician or other physicians to rule out other causes of stroke or to continue with certain management therapies. There are other referrals that should be made in some circumstances, for instance, the secondary stroke prevention clinic, which we'll talk about in a minute, to the March of Dimes post-stroke transitional care program, which again, we'll talk about in a couple minutes. So all this should be fully established and relayed to the patient and family at discharge. So the secondary stroke prevention clinic, briefly, is a clinic meant that each major facility in the Northeastern Ontario Stroke Network, which is Sudbury, Sault Ste. Marie, North Bay, and Timmins, does have access to, and patients should be referred from the inpatient setting as needed. That's not to say every patient will require referral to the stroke prevention clinic, but certainly if there's still questionable causes of stroke, they should be referred. Really, the goal of the stroke prevention clinic is to make sure we're doing everything and all that is possible to prevent another event from occurring. So that's to look at the modifiable and non-modifiable risk factors. In particular, make adjustments in the modifiable risk factors in order to prevent another event from happening. The post-stroke transitional care program is established in all 4 of the major hub hospitals. So in Sudbury and Sault Ste. Marie, North Bay, and Timmins, the post-stroke transitional care program provides services to assist stroke patients in transition from hospital to home, which is a very big step for many patients. They continue some rehab services. Most sites have collaborate with occupational therapy, physiotherapy, and speech language pathologists, and have a rehab assistant working along with them. And it's also a place for social networking for stroke survivors. And I've heard a lot of stories from stroke survivors about how important it was for them to have access to the March of Dimes programs, to be able to connect with other people who've had similar experiences as them. And so this is ultimately my last slide. It's the Road to Recovery After Stroke slide. This was established and created by the Northeastern Ontario Stroke Network. And it really paints a big picture as to what the stroke journey looks like from start to finish. And as you can see, the hospital portion on the left side is really a small piece of the puzzle. Patients, after they go home, have a big, sometimes have very, very big changes and must go through a lot of steps, both physically and otherwise to reestablish what their baseline would be and to reestablish, control over their lives. So this is just highlighting how important it is to have a strong structure post-hospital. And it is the Northeast Stroke Network did a very great job in highlighting this, how important it is to have follow-up care and how all the pieces fit together from start to finish. This is an example of Timmins and District, but really is similar in a similar process should be followed in essentially all facilities. So with that said, that wraps up and concludes my portion of the presentation. I appreciate everyone's time and attention throughout the presentation, and hopefully you enjoy the rest of them. And so this presentation was guided from mostly the Canadian Stroke Best Practice recommendations and its website. However, we have several references that we use to guide our presentation today. And so here's a list of the big ones. So I hope you learned a lot from our presentation, and you continue to learn as you hear the other presentations after your lunch. Thank you.
Great. Thank you, Nick and Deanne, for that great talk. A lot of information over the past 50 minutes or so. So if anyone has questions, you can type that into the chat box. Deanne's not able to be with us for the questions, but Nick is going to do his best to answer them. As well, I want to remind you to click on the evaluation survey for this session. It can be found on the right-hand side of your screen. So the first question is, what do you think as an RN triage nurse could you do for that patient to improve door-to-needle times if family drives them to the ER and just takes a number?
That's a really good question. And so I think the answer to this is simply to follow the protocol as much as possible. So as a triage RN, you should know the protocol fairly intimately. At Timmins and District, I believe, and I believe at most sites in the Northeast, we have signage in emergency to inform patients to present to triage immediately if they're exhibiting any fast symptoms, so facial droop, arm weakness, leg weakness, possibly too, and or speech changes. And so the triage nurse should then promptly assess the patient based on the CTAS mapping, which is available to them. This would include, in particular, the onset of symptoms, do a stat glucometer, and then CTAS the patient appropriately. And so ultimately, if they're within 24 hours of stroke-like symptoms, we should notify the emergency doctor's stat to get the process rolling and get the patient ready for an urgent CT scan, which will be necessary to manage care from there on out. So that'll kick off the process, and the rest of the pieces should come into play after that. So I hope that answers the question to the best.
Yeah, really good. Thank you. Our next question, how often should the whiteboard above the patient bed be updated?
Good question. The whiteboard should be updated whenever there are tangible changes in the patient status. So for a quick and easy example, if a patient transitions from thick liquids to thin liquids, this should be made clear immediately. So again, if a speech language pathologist makes that determination, they should probably be the ones responsible to changing the whiteboard, which they are. And certainly at Timmins and District Hospital, this is the policy we follow, and I believe would be similar for all other sites. The whiteboard should be created as soon as possible upon admission. So as each discipline sees the patients, they should, and determines what is feasible for the patient in terms of care and follow-up plan, they should make that clear on the whiteboard as soon as possible upon admission.
Perfect. Thank you. Just had a new question come in. What do you use for your NIH and TORBEST certifications?
That's a great question as well. So I'll start with TORBEST. TORBEST certifications is through speech language pathologists. So it is I believe, and I might have to get back to you on this specific detail, but it's an 8-hour session with speech language pathologist, 4 to 8 hours, and then 2 observed completions of the TORBEST. So the speech language pathologist at our site will observe us complete it twice, and if we're successful, then we will be a certified TORBEST administrator. The STAND tool is another tool that is used in some other sites. I can't really jump into too much details there, but I could certainly send an email off to participants to inform them as to what process is like to get certified for STAND. But certainly at Timmins and District Hospital, that's our policy for the TORBEST. As for the NIH, what we did is provided online service, so online learning module that was through LMS that was mandatory for staff to use and to go through. It primarily consisted of a resource through Apex Innovations, which is an online learning bank, essentially with what has modules that teaches each of the facets of the NIH. The NIH is a 13 has 13 different aspects to it, and it provides modules for each of these different assessments. So whether it be for arm, vision acuity, ataxia, so on and so forth. It takes about 3 hours on average for staff to complete this training. Once they do it and they pass the test through Apex Innovations, we then do a hands-on observation with one of our more trained and skilled NIH certified NIH personnel. So in our site, that was me. But certainly each of your sites would have someone who is ideally well trained in NIH usage and would be able to provide that in-person guidance for the first observation. Afterwards, at that point, we're pretty confident that people are able to administer the test appropriately, and we essentially green light them to go ahead. So that's how our process goes. And if you want more details, feel free to email me or contact me at Timmins Hospital, and I could go through this with you in more detail.
If I could add to that, Nick, people can contact their district stroke coordinator in Timmins, Sudbury, Sault Ste. Marie, or North Bay, and they could find out more specific information around TORBES training, STAM training, NIH training. And they also have access to key codes that are required for the Apex Innovation training at the NIH. So if you contacted your local district stroke coordinator, you could get a free key code to be able to start the process by doing that online training. All righty.
Yeah, thank you, Sue, for clarifying. Yeah.
Yeah, it's good. And then I have a question about the stroke community navigators. So when would you refer to them? Is it in acute care? Is it rehab? Is it both? Can you just tell us a little bit more about that program?
Yeah, the Stroke Navigator program is primarily for patients who are discharged from the hospital after having an acute stroke or after they had gone through a phase of rehab. So with that said, they're primarily meant for when they're transitioning from hospital to home. And so referrals should be made as we're starting to get a good idea as to discharge date. It's probably not ideal to have to send the referral on the discharge date. At some sites, I know the navigator actually goes to the hospital and does an assessment with the patient while they're actually still in an acute or a rehab bed. And that's really beneficial for both the patient, the family, and the navigator to, it's best for continuity of care. So that's ideal. COVID has changed things slightly where we're often doing referrals as they're being discharged. But hopefully we can kind of revert back. And this is the case in Timmins. This may not be the case for our other navigators in the other communities. But hopefully we can revert back to the inpatient assessments soon, perhaps once we get through this next wave, which has been fairly detrimental to the system. But so ultimately, the ideal time to refer is as they're approaching discharge, so within 3 to 5 days of discharge date.
Perfect. Thank you. So I think that's all the questions that we have coming in. So I just want to thank you, Nick, again, and Deanne as well for great talk, lots of information shared.